Good afternoon, everyone. Welcome to this webinar entitled Dermatologic Ultrasound, Clinical Applications, presented by Dr. Fernando Alfajeme. Today's webinar will cover clinical applications of dermatologic ultrasound. The AIUM is accredited by the ACCME. This webinar is designated for one AMA PRA Category 1 credit. By the conclusion of this webinar, participants will be able to understand the basics of dermatology for radiologists, explore the clinical applications of dermatologic ultrasound, and create a suite of services to dermatologists regarding ultrasound examinations. As an ACCME accredited provider, it is the AIUM's policy to ensure that the content and quality of this activity are balanced, independent, objective, and scientifically rigorous. At the conclusion of this webinar, you will be able to access the CME test located on the AIUM website. For more information on accessing the CME test and claiming credit, please refer to the handout provided in the dashboard on the right side of your screen. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Dr. Fernando Alfajeme and Darcy Benito de Luna have no disclosures. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During today's presentation, if you have questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time he will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now I'm pleased to present Dr. Fernando Alfajeme.
Good afternoon, everyone. This is Fernando Alfajeme. I am a dermatologist from Spain. I am also a director of the Ultrasound Learning Center for EFSUM, that is the European Federation of Ultrasound of Medicine. That's something similar to IUM, but in Europe. And I'm also collaborate in IUM as a vice chair with together in the chair of Jimena Boltzmann in the dermatologic ultrasound group. Well, the title of the seminar today is Clinical Dermatology. What can we do with ultrasound and what we can offer to our dermatologists so that they require our services, and how can we convince dermatologists to start requesting ultrasound, the utility the ultrasound may have for dermatologists. Then, as I am a dermatologist, I can tell you more or less what we require. That's something that sometimes is much more a matter of communication between specialists, as you will see, than really the applications that are numerous, and the possibilities are enormous, as you will see. The only thing that is difficult is going to be the after this webinar, how you convince your dermatologist that you can offer services, things, information that may be relevant for a better management of their dermatologic patients. Well, let's start with that. What do really dermatologists want? Huh? Okay, dermatologists want. Okay, this question that Sigmund Freud said, well, what do dermatologists want? What are they requesting? What's in the head of the dermatologist? That's an important question, because if you know what is in the head of the dermatologist, you can ask or offer what they are asking, even if they don't know what they are requiring now. What do they really want from ultrasonography? Well, in this sentence is resume what a dermatologist may need regarding dermatologic ultrasound from us as professionals doing ultrasound. Dermatologists require useful information that they can understand, that intelligible information, to offer to their patients, to offer more value to their patients for a best personal treatment. And these three parts, this useful, intelligible information for best personal treatment is important. It's important because the dermatologist must know what you are saying. Because in some reports, we sometimes read from our colleagues here in Spain, maybe, I don't know, that's something that maybe not happening in your country, in the States or in other parts of the world. Some reports are in a specifically located, ill-defined hypoechoic structure to correlate with clinical picture is of not use to us as dermatologists. It says nothing, and it gives no value that I can offer to my patient. Then if I receive 2-3 reports like this, I will stop requiring dermatologic ultrasound. I need valuable information that it's helpful for me to better treat my patients. Then sometimes it's not the fault of the radiologist, it's the fault of the dermatologist because they don't know what to ask. For example, this is the requirement of a colleague of mine that requested an ultrasound of me, and he said, well, please diagnose and indicate best treatment for in a specific erythema. Well, this is she or he is not doesn't know what she's asking for or what she's looking for. Then if she or he, your colleague, is not knowledgeable about what he or she wants, you cannot give what she's asking. This is not a reason to ask for an ultrasound, a dermatologic ultrasound. Then sometimes we have this kind of films with the dermatologist who is not able to see and the radiologist who doesn't understand really because she's not able, or he or she is not able to understand what the dermatologist is asking, and this leads to the failure of dermatological ultrasound. Then good communication, giving good information that it is useful for a better personalized treatment for the patients of the dermatologist is going to be key if you want to start doing ultrasound for your dermatologist. Let's go with the three main fields in which dermatologic ultrasound is useful, and I'm going to explain you what information is relevant for us as dermatologists and that you can offer so you can improve your relationship with your dermatologist that are going to require your exploration. As you remember, skin cancer can be divided into two types, the melanoma skin cancer and no-melanoma skin cancer. The most frequent one is the no-melanoma skin cancer. This is basal cell carcinoma and squamous cell carcinoma mainly. We also have melanoma skin cancer that is less frequent, hopefully, but it's more important to have a correct and accurate diagnosis. Then ultrasound can be key in the management, and now is key in the management of this patient, mainly in melanoma skin cancer with new treatments. As you know, the new therapies for melanoma skin cancer are starting to make this disease not as fatal as before. We have not chronic patients with melanoma, and follow-up is made mainly with ultrasound, and you can offer this follow-up for new treatments with new treatments and nivolumab, dupilumab, and other treatments that make this kind of non-melanoma skin cancer chronic. But in the follow-up, ultrasound is key just to evaluate the state and the progression or the cure of these kind of cancers. Also, in melanoma skin cancer, this is important because sometimes surgery must be directed in order to avoid complication or incomplete resections. Then ultrasound can be key, and that's information that you can offer to your dermatologist too. This is melanoma. Melanoma is hopefully not very frequent now. Its frequency is more or less one here in Spain would be 1 out of 100,000 every week we get here in Spain. Maybe in Australia, as I know, we have some attendance from Australia, is really more frequent, and in the States it's even more frequent than here in Spain. There's a lot of melanoma that fortunately are detected at the very beginning with the lower stages. This melanoma, as you know, it requires a good staging. Good staging is local staging of the tumor and regional staging of the tumor. We can offer a kind of sonographic breast load with high frequency probes. Now we are able to give our dermatologists the depth in millimeters that correlates very well with the histological breast load. Now here in Europe, we are starting to have a different strategy of treatment or surgical treatment with ultrasound. Instead of first biopsying the melanoma and after making an ampliation of the margins with the Breslow index, we sometimes with the sonographic Breslow take the decision to make the surgery just in once, not in 2 steps as it is conventionally done. This is good for the patient and it's oncologically correct because there's a big correlation between the Breslow, the histological Breslow, and the sonographic Breslow. We can also assess near structures that is correlated with the T and the TNM classification, and we can also assess metastasis. In transit metastasis, nodal metastasis now are very important because the early detection is key to have the opportunity to cure the patient with new treatments. And as I told you, there has been a recent revolution in the treatment of melanoma patients regarding these new treatments, and the early detection of these metastasis or micrometastasis with ultrasound can be key for the cure of these patients. And I say cure because until when I started my residency, if you got a node, an affected node, the prognosis was going to be fatal. Your possibilities to survive 5 years decreases a lot. Now, with early detection of micrometastasis or in transit metastasis, patients have opportunity of have a longer survivance and a more quality of life. Just to remind you some features of this kind of tumor, this melanoma is hypoechoic, very hypoechoic because it's very homogeneous cellular tumor type, and it is the tumor that has higher vascularization and it's correlated with the breast load of the more vascularization, the deeper the tumor will reach. As you may remember, the breast load that is measured in the image you have seen in your left, you can measure the breast load going from just below the hyperechoic line until the deepest hypoechoic area of melanoma. This is the Breslow index. In this case, the sonographic Breslow has a big correlation with the histological Breslow. This is another kind of tumor. This is basal cell carcinoma. Basal cell carcinoma is the most common skin tumor in the human, malignant skin tumor in the human being. This mostly 1 out of 5 people will have a basal cell carcinoma. That is very frequent. What information can be given with ultrasound? You can assess which skin structures are invaded. Then you can assess if only epidermis to detect superficial basal cell carcinoma, dermis of subcutaneous tissue, or even muscular structures of the face or the scalp are affected. And basal cell carcinoma is a first line, as Jimena Wortman said, for the evaluation of this kind of tumors, because staging is very, very precise, and you can plan your surgery with previous disintervention. Sometimes we dermatologists tend not to do many image studies before a surgery. And then when we will go to the operation room, we find surprises that are not very nice sometimes. With ultrasound, you get certainty of what you are going to find in your operation room. That is very comforting for us as surgeons, as dermatologic surgeons. Most dermatologists are also dermatology surgeons because our specialty is medical and surgical, both of them. Most dermatologists do both things. And you have to take into account that dermatologists are both doctors, both medical doctors and surgeons. And this surgical information can be very interesting also for your dermatologist. Diagnostic clues regarding this kind of tumors is that this tumor is hypoechoic, it will have hyperechoic dots, and the vascularization is moderate. These hyperechoic dots are very correlated with the histological grade and the histologic aggressivity of the tumor. The more hyperechoic dots we have, the more possibilities of recurrence we have, as it is an expression of the number of cells of the nests of basal cell carcinoma, and it's an indicator of recurrence and aggressivity too. The more hyperechoic dots, that's some information that you can also give to your dermatologist, the aggressivity, the sonographic aggressivity of the tumor regarding this correlated with this number of hyperechoic dots. This is another very frequent carcinoma. This non-melanoma skin cancer, that is squamous cell carcinoma. Squamous cell carcinoma of the skin is quite frequent, not so frequent as basal cell carcinoma, but quite frequent, and it's really underdiagnosed. And sometimes we diagnose it when this tumor has invaded a deep structure because it's invasive. As you may see from the images, it has not so well-defined borders, and it has the possibility of metastasis. Then you should assess both the nearby structures and both the next nodal stations when you are starting this kind of patients. Then why ultrasound may be relevant in this kind of tumors? We know that a high risk squamous cell carcinoma are those who are more than 2 millimeters. When this tumor reaches more than 2 millimeters, it's high risk. It has high risk of recurrence. Then sometimes surgery must be more wide or combined with radiotherapy. When near structures are there, we can assess if there's some kind of invasion. For example, in the scalp, the relationship with the bone is important, with the diploid of the skull is important sometimes, or even in the relationship in the areas of cartilaginous areas, to see or to assess if resection of cartilage is necessary or not. That's something very important for pre-surgical planification, and you go to the operation room with another idea if you made this kind of surgical planification. Some dermatologists think that it's not important that you go to the operation room and you find whatever you want to find, but sometimes it gives you surprises when there's infiltration of the bone, and you could have none with the entirety. You can avoid this kind of disgusting surprises. And you can also assess metastasis, because this tumor may also have metastasis, near metastasis or far metastasis. The diagnostic look for this kind of tumor tends to be heteroechoic, irregular margins, as you see, and it reflects this behavior, this invasive behavior, and it has also high vascularization, more than basal cell carcinoma and less than melanoma. There are other kinds of tumors that you can also assess with ultrasound. That would be Kaposi sarcoma, that can be also detected with ultrasound, and Merkel cell carcinoma that can also be assessed. And it's good when you are trying to make a kind of surgical planification in these kind of tumors. It's always good to have a plan before you get into your operation room. That's something that most dermatologists don't do. And if you can convince that they can go to operation room with a more confident and faster, because our operation rooms in dermatology must be very fast. So because surgeries are very limited in time. Then if you have a planification before surgery, you can make even more surgeries in one day. That's another another thing you can offer to your dermatologist. As I was telling, the important part in this webinar, maybe not the images, or maybe not the real sonography, or the things that you from the seminars by Jimena Bosman and Dr. Catalano have been seen, but how to convince your dermatologist that ultrasound may be of usefulness to them. The other big part in dermatologic ultrasound is inflammatory skin diseases. We go now from the cancer skin diseases to the inflammatory skin diseases. Inflammatory skin diseases are very frequent. Some say that inflammatory diseases in dermatology is the science of naming red skin in 10,000 different ways. There are at least 10,000 different diseases in inflammatory skin diseases. If you go to a classic book, you will see that the number of different inflammatory diseases in dermatology is enormous. Then most of the times diagnosis is not going to be the role of dermatologic ultrasound, but for a couple of diseases that we are going to deal with. But we can offer information regarding the kind of inflammation and the extent of inflammation, so that we can select the best treatment for this patient. This possibility of personalization of individual medicine for your patient is something that is very valued by dermatologists. And our patients now, when we are doing treatments in inflammatory skin diseases, demand us this ultrasound. And if they don't see, because we teach the patients to see the dermatologic ultrasound, they can see that inflammation is more or less. And the very patient requires us this dermatologic ultrasound. We have been teaching our patients that dermatologic ultrasound is important because we can personalize the treatment to his or her case. Then it's a work of education of the patient that also can be done by the dermatologist or by you as radiologist. When the skin becomes inflamed, these areas tend to be more vascularized. We have more Doppler signals, and the echogenicity starts to be decreased. If you remember the wonderful webinar by Dr. Catalano, you should always identify these layers of the skin, the epidermis, the dermis, and subcutaneous tissue, that in the case of inflammation, it starts to be less echogenic, more hypoechoic, mainly in the upper dermis because of the superficial plexus that is located in this area. And in the subcutaneous tissue, you will see that instead of the hyperechoic septa that are usual in this area, you will have those hypoechoic septa that are a hallmark of paniculitis, of inflammation of the septa of the panniculus, together with the more echogenicity of the fatty cells that is reflected by hyperechogenicity of the subcutaneous tissue. This is a nice example of viral wart that is something that is very commonly being treated by us dermatologists or podiatrists. You can also offer this service to your podiatrist because you can assess the extent of inflammation. In this case, the inflammation would be the hypoechoic area marked with the W, is reaching the epidermis and superficial dermis, not reaching the deeper part. Then you can assess if this wart is going to be tough or not whenever you are treating, and even predicting if the patient is going to need 1, 2, or more treatments by your podiatrist. The case of lichen planus, you can see activity. Sometimes in some inflammatory skin of diseases, you don't know if the inflammation is active or not, such in the case of lichen planus, or sclerosing diseases as morphea, as you know, that sometimes it's very difficult to identify if the active if the lesion is active or not. That is important because if the lesion is active, it will need anti-inflammatory treatment comparing with the fibrotic state. In fibrotic state, the treatment will be different, totally different. It's something that you can also offer to your dermatologist when you are treating this kind of diseases such as lichen planus or morphea. You can also assess the inflammation of follicular elements, as Jimena and Orlando have already told you, with dermatologic ultrasound and high-frequency probe, in this case 22 megahertz, we can assess the inflammation of the follicles. In this case, it's a case again of tinea capitis, but also in the cases of alopecia, we can also assess which is the state of the follicle. That is, sometimes it's not so easy to assess from a clinical point of view because the inflammation is deep. In the case, for example, of lichen planus or frontal fibrosing alopecia, the clinician sometimes do not know if there's signs of inflammation. Then your ultrasound may be useful to assess the inflammatory state to decide active treatment or observation. And to make a resume regarding these kind of diseases, these inflammatory skin diseases, we can assess with ultrasound if there is inflammation. That is easy, but it's when it's red. But some inflammatory diseases, as the deep inflammatory diseases, are not so easily evaluated as the more superficial. Where's the inflammation? In the epidermis, dermis, subcutaneous tissue, because most of the times when the inflammation is reaching the lower dermis of subcutaneous tissue, systemic treatment and even biologics are going to be needed, and quantified inflammation. Is there much inflammation? The inflammation is improving with treatment or not? A special case in dermatologic patient is hidradenitis suppurativa. Hidradenitis suppurativa is a devastating inflammatory disease that is affecting more or less 1% of the population here in Europe, and is characterized with this kind of lesions that from outside are the same. This lesion, then maybe some of them are red, some of them have this kind of nodular lesions, more erythematous, or with this kind of fistula tract. Sometimes it's not very easy to detect where is the nodule, where is the fistula, or where is the abscess. It is important because a fistula is not treated the same way as a nodule, and a nodule is not treated the same way as an abscess. Fistula tract indicates more aggressive diseases that may be even require biologic treatment. Then for the selection of treatment, ultrasound is key in this kind of disease. This is a model in which ultrasound has been key in understanding a better treatment in this kind of patients. I recommend you to read this wonderful paper by Dr. Borsman regarding this characterization of these lesions in this patient of hidradenitis suppurativa. As Jimena described, there's a gradient of inflammation that is correlated with the inflammation of the patients and with the stage of the patients. At the beginning, the follicular widening and dermal nodes indicate that the inflammation is mild, but when liquid collection and fistula start to appear, then the disease is starting to be chronic. Then it's a no return point that should not cross, otherwise surgery will be required. This is quite similar to what it's happening with Crohn disease. If we get the Crohn disease at the beginning and we treat it early, we are able to stop the disease. This is the same that we are seeing now in our patients of hidradenitis suppurativa. Then, if you see this patient from the clinical point of view, it's all the same. It's all red, all weeping, all painful. There's not real correlation of clinical with what is really happening. The only way to see beyond the skin of this patient is ultrasound, the only one, remember. And we can also assess the evolution of our patients with hidradenitis suppurativa. For example, in this case, that is treated with rifampicin and clindamycin, that is standard antibiotic treatment in this kind of patient, we can see that inflammation is decreased in 12 weeks. Well, the patient will tell us that he or she is better, but we can make it also quite evident for the dermatologist and for the patient, because our patients are taught to see their own ultrasounds so that they can see if the treatment is working for them. This personalization, as I've told you, is very important in the relationship of the dermatologist with the dermatology patient and even with you. Well, we've seen cancer, skin cancer, and the utility of skin cancer. We've seen the utility in skin inflammation and inflammatory skin diseases. Remember, hydrogenated supraactiva patients, and the evaluation is key, because sometimes we tend to underestimate the extension of the disease. And finally, something that has become an epidemic here in Europe and Southern America: the epidemics of aesthetics complication. Aesthetic complication is a common cause of consultation of our patients. In our patients, we are starting to see that they are coming to our outpatients with problems after the infiltration of this kind of dermal fillers that you will see that they are not dermal fillers really. They are subcutaneous filler. This is a case that came to our clinics. The patient came regarding these venous lesions in the lower lip. As you see, this venous lesion in the lower lip, and she wanted them to be removed with lasers. When we explored her, we saw this image. That, as Jimena or Orlando will have told you, corresponds to a snowstorm pattern that is correlated with silicone oil and polyacrylamide, with polymethyl methacrylate, that can be related with these two kind of dermal fillers. Then in this case, there was something that was beyond these little veins that she wanted to be treated. If we had shot with our lasers these kind of lesions, we would have activated this filler, and the patient would have had problems. Then, the thing is, the last one who touches the patient is going to assume all the consequences, good and bad, and the complications. If we had had our lasers in this patient, this filler would have been activated and inflammation for months would have been started. Hopefully, we saw this implant and we refused to treat this patient, avoiding this complication with lasers. Then what is the information we can offer to our dermatologists that are interested in assessing a patient with fillers? First of all, if there is any filler, we can see easily if there is a bump, but sometimes the filler is not so evident from a clinical point of view. And I tell you, most of the patients are going to tell you that there is no filler, that they have never had any filler, because I don't know if it's something related to shame or something they want to hide to their wives or to their husbands. I don't know, but people tend not to say to their physicians that they have fillers. We can also assess where the filler is located in epidermis, dermis, subcutaneous tissue. What kind of filler is there? Is it non-resorbable or resorbable? That is important regarding the prognosis if there's a complication. And if there is complication related to the filler, and we can see the extension of the complication and the prognosis of this complication. Remember, always refer to this kind of schema of the skin with the epidermis, dermis, and subcutaneous tissue. Where should we look for our filler? Mainly in this area, in dermal junction for superficial fillers and subcutaneous tissue for deep fillers. Then this is the area you have to look at. Remember that there are two main kinds of fillers: the silicone oil filler, non-resorbable, and the non-silicone, the silicone and the no silicone. In this Non-silicon that are more numerous is the hyaluronic acid, acrylamide, and other, as polylactic acid, hydroxyapatite, and so on others. You have to identify this snowstorm pattern because it's quite frequent. Now silicone oil is not permitted in America and Europe, but it's something that we still find in our oldest patients and those who have gone to South America for treatments. Then this snowstorm pattern is quite common, and sometimes it can be from clinical point of view can be confused with diseases as scleroderma or morphea, when we in the depth we have this snowstorm pattern. This snowstorm pattern is mandatory to be discarded when we suspect a complication of a filler. The next pattern is bacular pattern. This bacular pattern is very common because now the most common filler that is used is hyaluronic acid. Hyaluronic acid and polyacrylamide have this kind of bacular pattern. This is the pure hyaluronic acid and pure polyacrylamide will have this kind of bacular pattern then that we can assess. And a third pattern that is important to know is this cottony pattern. This cottony pattern is the evolution of another kind of pattern, this evolutive pattern of hyaluronic acid, of the reaction to any kind of fillers. We have this kind of dirty image in the subcutaneous tissue that blurs the dermal-subdermal junction. You can see some vacuoles that are also related to the previously implanted filler. This is a case in which we had a recurrent periorbital mysterious inflammation in a patient, and when we started exploring this patient, we saw this snow pattern that was compressing. As you see, they were compressing the superficial veins, therefore producing a stasis in the veins of the face of this patient. Then the solution to some of these bumps that appear and disappear in the face sometimes is the presence of fillers. It's good to discard that the patient is filler. It has a filler. And then when this bump appear and disappear, it must be discarded. Sometimes the use of elastography, we can detect too the presence of these fillers that can be camouflated, because the patient that has fillers tend to have not only one kind of filler. They tend to mix as layers of one of another, after another. They have at the base maybe silicone oil, and if she or he has had an implant in the 90s, she would have had polyacrylamide, and in the early 2000 hyaluronic acid, and you can see at the earth strata how this kind of deposit are can be located. Sometimes they are quite invisible, and you can detect them with this elastography that is useful to detect this subclinical or sub B mode, let's say, acrylamide or hyaluronic acid vacuoles inside the silicone oil implant that this patient had. A couple of words regarding skin elastography. That's something that you can also offer to your patients. This is kind of this skin elastography. In this skin elastography, you have you can also assess with superficial probes the elastography of normal skin. Normally, dermis tend to be more hard than subcutaneous tissue, more or less with this kind of relationship. You can also do with new equipment shear wave. And skin cancer tend to be harder than normal skin. That is something that is maybe not very useful, but you must know that in case of doubt, these kind of tumors tend to be more stiff. And something in which this can be interesting is in sclerosing diseases. That's morphea. In morphea, the skin tends to be stiffer, and in the follow-up on treatment, active treatment or restoration of these patients, elastography may be a useful tool you can offer to the dermatologist to make a personalized, close follow-up for detection of subtle changes in morphine that sometimes, as this is a deep disease, is not easily assessed by inspection or palpation. Sometimes in our melanoma patients, we have very small nodules that sometimes are not even palpable. This is a case of an axilla of a patient of us that has had this very small node that was very doubtful with EB mode, and even with Doppler, the measure was 3 millimeters. Then with elastography, we were able to detect this subclinical sub-B mode lesion that flare up in red, that in our equipment is hard, and permitted us to detect this micrometastasis. As I told you, early detection in melanoma is key because it gives the opportunity of the patient to have a very long survivance with new treatments. Then early diagnosis is key, even in this sub or millimetric metastasis that will require systemic treatment with new treatments. And sometimes, as I've told you, we can detect some implants that were not so evident. To conclude, as you've seen, dermatological ultrasound is an application that has come to stay. You will start to see more publications, more papers regarding dermatological ultrasound, as there are more radiologists doing dermatological ultrasound and more dermatologists doing this dermatological ultrasound, and we have to collaborate to make the most of this technique. I think that is good. It's a win-win relationship. This dermatologist-radiologist relationship is good. This information must be useful, and if we are able to optimize and personalize the treatment of the dermatologic patient, is going to be valued by both the dermatologist and the dermatologic patient. The good education of the dermatologist and the dermatologic patient is good for you regarding what you can offer. And this communication, understanding the necessities of the dermatologist and radiologist are key to make this perfect tandem. This is my email if you want to contact me regarding any kind of question. And now, if Darcy is so kind, we can answer the questions you have been making during this webinar.
And at the moment, we have one question.
Okay.
They're asking if there is a database of ultrasound of skin cancer available for study and research, and if so, where could they locate that?
Well, there are a participant is asking now why if there's any kind of registry of skin cancer. The answer is no. The answer is no, but we must do it. We must do it. Why? Because of two things. First thing is because making this kind of images available for everyone is a useful resource, educational resource. And two, thinking about future artificial intelligence ultrasound diagnostic methods, it can be very good for big data in cases in which we are not very sure about the diagnosis of the patient, and the implementation of artificial intelligence regarding this kind of images can be good. Then there is no registry. We must do it. It's a very good suggestion. Some radiologists here in Europe are starting to ask for it. We are looking for someone to help us regarding this registry. This is an invitation for sponsorship too regarding this kind of registry. And regarding future of dermatologic ultrasound, I think that regarding artificial intelligence, that would be good because it's material that can be analyzed by neural networks. It's quite very interesting, thinking about the future.
Great. Okay, so we've got a question here asking about how a wart would appear on power Doppler function on ultrasound, and would it be vascularized or different from melanoma?
Which one?
A wart.
A wart. Okay.
Yeah, how a wart would appear on power Doppler and ultrasound.
Yes. Nowadays, we are not able to differentiate inflammatory vascularization from tumoral vascularization. Then nowadays, with a simple power Doppler or spectral Doppler or color Doppler, we are not able to differentiate inflammatory, as it is words, from tumoral. However, I think that in the near future, if we start to study the patterns of vascularization of our tumors, we will be able to differentiate them. Both the general pattern, the architectural pattern, the spectral one, but even the flow inside. Then the answer in this case is not now. We are not able to differentiate, but that's something that we are investigating now. The different patterns of inflammatory skin diseases compared with tumoral lesions.
Okay, and we actually have a second wart question.
Oh.
They're asking if you're familiar with ultrasound-guided injection of bleomycin. Did I pronounce that correctly?
Yes, bleomycin.
Bleomycin for warts.
Well, bleomycin is a treatment that is commonly used in warts, and we have done a couple of cases. The main advantage is we can reduce the volume. As you know, bleomycin is very painful, and this pain is related with the volume too, apart from the substance, with the volume. Then we are able to inject very small quantities just in the focus of the wart. Then it's advantages from the common practice that's doing it blindly, in which you tend to inject more volume. This is the same that happens in hidradenitis suppurativa. In hidradenitis suppurativa, that we tend to inject with corticosteroids, we infiltrate the viscous tracts. We inject more or less half of the dose when we are treating with ultrasound guidance. Then I think for us it's important that all the injections are ultrasound guided, because we can give more accuracy regarding what we are injecting, and the quantity tends to be less when you do this with ultrasound control.
Okay. Now we have somebody wondering your thoughts about cellulitis versus abscesses with ultrasound.
Well, regarding the differentiation of cellulitis and abscess, it has been published in quite a lot of papers, on at least 20 papers, I think, in emergency room scenarios, to differentiate abscess from cellulitis, because from the sonographic point of view, they are totally different. An abscess is an hypoechoic area with vessels around, and this can be drained. While in cellulitis, there is hypoechoic areas that are less defined, and you have vessels inside. In these cellulitis areas, you cannot drain. In case of doubt, you can do also this skin elastography. With skin elastography, the collections, the fluid collections, tend to be softer than the cellulitis. Then yes, they can be identified. Yes, there is evidence regarding this question. It can be, you can detect clinical and subclinical abscesses that sometimes are the cause or of the bad results of some treatments, some antibiotic treatments. Because if you have an abscess, it must be drained, really. And if you don't detect the abscess, it cannot be drained. Then prognosis of abscesses, even more in the subclinical abscesses, can be modified with the performing of ultrasound. And there's something that in emergency departments, even more in children, dermatologic in wards, in emergency wards, it's key. It's key. Just to make this ultrasound to discard the presence of these kinds of abscesses. Then it's a helpful use and useful tool to make this kind of distinction. Yes.
Great. So the next question isn't quite a question, it's more of a clarification. They're asking, so non-silicone fillers have either vascular or cottony pattern versus snowstorm patterns in silicone filler. Is that correct?
Exactly, exactly. This cottony pattern is a pattern in which nearly every resorbable filler can be converted into this cottony pattern. Silicone oil pattern, snowstorm, tend to be a silicone oil pattern, no storm pattern. Usually, there's no conversion, but this vacuolar pattern, another that is shared by some fillers, and some other fillers share this kind of cottony patterns. This cottony pattern is an evolutive pattern, let's say. Silicone oil tend to be stable for years, even if it has been infiltrated 20 years ago.
All right. What are the applications of ultrasound in vascular skin lesions?
This is very interesting question regarding the use of vascular ultrasound lesions. And here in Europe, and I think that also in America, if you send a patient for lasers, the usual thing is to shot the laser and then ask what kind of lesion is. Then we tend to fire and then ask. We are changing that because it's good to have a good diagnosis before shutting something with your lasers. Why? Because there are two main kinds of vascular lesion. You have the vascular tumors and vascular anomalies, as you have seen in another seminars I've seen in last webinar, and that you were seeing this kind of vascular lesions. You have these high flow lesions, and these high flow lesions are not very good for lasers. Then the possibilities of success of treatment are lower in these high flow lesions. Then you can select the patients in which lasers are going to be useful. And you have also the correct diagnosis before shutting the laser. Then yes, it is useful. You can distinguish the different kind of vascular anomalies, both tumoral and vascular anomalies malformations, and you can plan which kind of treatment is more accurate for this specific vascular anomaly. Then I think for me and in our department, pre-surgical or pre-laser evaluation of this kind of lesion is key. It has changed our blood workflow, and we are much more successful. And the patient, as I told you, has been educated that before lasers or before laser surgery, he or she must have an ultrasound that she understands. This patient education is very useful because the patient is going to value what you are doing for him, and in understand the well. It's very pedagogic for the patient and for the dermatologist.
Okay, and I am not seeing any more questions. So this is great. Well, thank you very much for this insightful webinar. And on behalf of the AIUM, our thanks to all of you who participated today. Please complete the activity evaluation and remember to visit the CME Center on our website for the post-test. We hope you enjoyed this presentation and you'll join us again for future webinars. Good afternoon, everyone.